Thank you, Dr. Somshila, and thanks to Dr. Namrata Sharma and Dr. Muralidhar in particular for having me over here. Children are not mini adults. They are little people by themselves. So their medical care should be exclusive. It should not be extrapolated all the time from adult care. I'm Radhika from Shankar Netralaya. Can you see my slides? Are my slides visible?
Yes, Dr. Radhika, I can see it.
So today I'm going to talk to you or just show you a bunch of my cases of immune external eye disease in youngsters. So lid margin disease we know is very common in children. It could be anterior blepharitis or it could be posterior meibomitis. And the blocked oil glands are an outcome in the hormonal active peripubertal age group. And these tend to cause dandruff in the hair, acne on the face, and also meibomitis. So all parts of this triad need to be treated. And it's more the problem with the alteration in the quality of the oil secretion rather than the quantity, which causes bacterial colonization and in turn produce an immune reaction. You can see in the first picture that there is meibomian cyst, and where that touches the cornea, there is an immune reaction producing a catarrhal ulcer. These may look innocuous, but sometimes they progress to melt and perforation. So treatment should be with lid scrubs, that is the mainstay of treatment, along with lubricating eye drops and mild steroids, always with an eye on epithelialization. Sometimes when the lids are clean, but there are recurrent chalasia, we have to rule out underlying uncorrected refractive error because these children squeeze their eyes to produce a pinhole effect for clarity, and that alters the meibomian milieu. Rarely, there could also be underlying juvenile diabetes. Supportive treatment works very well with doxycycline. It's an excellent anti-inflammatory and a modest antibiotic. But in small children, there is fear of tooth staining, so erythromycin may be the supportive treatment of choice. This looks a lot like immune Blepharo-conjunctivitis. But if you look closely, the eye is very much congested and there is matting, and you can even see discharge accumulating in the canthus. This is Blepharo-keratoconjunctivitis due to or marginal ulcer due to HSV infection. So HSV Blepharo is an uncommon primary infection, but it's more common in children. Unlike the recurrent infection from the ganglia, this is a primary HSV infection. Why should we distinguish this marginal ulcer from staph immune? Because over there we give steroid. Here, if we give steroid, we can actually end up propagating the dendrites. So HSV primary disease in the form of Blepharo-conjunctivitis needs treatment with topical or systemic antiviral agent. So when you have blepharitis, it can set up recurrent fliccular keratoconjunctivitis. But when the lashes are clean, you have to look for other culprits like TB or chlamydia or sometimes intestinal parasites. I put up this bunch of slides of a patient of mine who had recurrent flicton. And it's only after his UTI was treated completely that the flicton went away, as you can see in the last picture. So this again was recurrent flicton in a boy. His lashes are clean, as you can see in the picture. He had no systemic disease, but we noticed a pucker in the flicton. So when we opened it up, we saw a large sand particle, a foreign body. This was a reactionary response. And after we removed it, he resolved completely. So this was a mimic. So here's yet another blepharitis, which is looking a little different. There you can see collarettes. These are cuffs around the eyelashes, which will prompt you to think about colonization with Demodex. Demodex is a common commensal, but sometimes it can morph into a mighty mite and set up ocular surface inflammation. Treatment is with tea tree oil, best done in the office, because if the patient does it themselves, it can cause toxic keratitis. This was reported in Corneal journal recently. And so we saw that there could be oil on the lid, there could be dirt on the lid, there could be mite. Scaling it up one level, you could have lice on the lashes. Tyriasis palpebrum, almost always associated with tyriasis pubis. This is commonly seen in children who are not cared for very well, those from foster homes and orphanages. Treatment is almost always systematic delousing with the help of a dermatologist. I've had the occasion to pluck off some of these creepies from the lashes of some less privileged children. Moving away from the lid, Episcleritis and scleritis are very uncommon in children. When they happen, there is usually underlying lupus or something, some immune disorder. Here was a 12-year-old child with flat nodular episcleritis. You can see it over there. There was no systemic illness. There was no first point to suggest an infection. We could see a homogeneous episcleral mass, as you can see there on the ASOCT. I'll tell you in a bit how she resolved. Yet another child of 10 years of age with similar kind of episcleritis. Her MAN2 was strongly positive, even by Indian standards. While reading the MAN2, it is important to note the area of induration rather than the erythema alone. And the strongly positive MAN2 in the absence of chest features is indicative of extrapulmonary tuberculosis. In this case, it was episcleritis. Both children were treated with AKT and steroids, and they resolved, as you can see in the last picture. This child, again, a 10-year-old boy, was treated for recurrent episcleritis elsewhere. Again, this disease is uncommon in this age group. When he came to us, he had a swollen nodule at the limbus, as you can see in that picture above. But he gave vague history of trauma. And when we stained with fluorescein, we got a diagnosis. You can see the cobalt blue picture. There is stippling of conjunctiva in that area. So basically, the conjunctival aberration never healed properly thanks to all the steroids that he was using, and the rawness produced an inflammation and edema. You can see in the slit picture that edema looking like a nodule where the arrowhead is pointing with adjacent Dellen effect in the cornea. All we did was take out the steroid, put him on lubrications with intermittent patching, and he resolved completely. We had yet another child like this in whom the treatment was done with Pros contact lens, under which his conjunctiva healed, and one more where we used amniotic membrane. So like recurrent corneal erosion, recurrent conjunctival erosion can be a rare but significant entity, and the history and fluorescein staining led us to the diagnosis in these two children. Speaking of recurrences, this is recurrent EBV keratitis. The SPKs are not tiny like adenoviral. They are not stuck on like microsporidia. These are classic crater-like SPKs of EBV. EBV is not common in our country. It is the contagious kissing disease of teenagers in the West. This teenager gave history of travel. Serology is important in infectious mononucleosis because presence of only IgG can mean a past disease. These SPKs will require only symptomatic treatment, whereas if there is a viral prodrome and the IgM is present in the blood, then it means the mono is active and may need systemic antiviral treatment. So Dr. Vanti showed you most aspects of keratoconus in a child, but the one that I would like to point out is that in this child who developed multiple infiltrates after cross-linking treatment. This was an immune response because these infiltrates were multiple, they were whitish in color, they came on too soon after the cross-linking, and the epithelium over was intact. So these 4 pointers led us to believe that this was an immune response to the dye. So we hyped up the steroid, which led to resolution, as you can see the scarring in the second picture. Microsporidosis, acanthamoeba keratitis almost always has an immune component. We know that. This is an 8-year-old child with micro-proven acanthamoeba keratitis. Even by the standards of acanthamoeba, she took very long to show any symptom of or sign of resolution. So in a hot eye, we added topical steroid.
1 minute remaining.
And slowly it started, yes, please. And slowly it started resolving, as you can see in the second picture. So the immune component of acanthamoeba is probably stronger in children and makes a case for early supportive therapy with steroid in AK in children. It's probably the most interesting case of the presentation, where this was of a 7-year-old girl with juvenile rheumatoid arthritis. She had septic arthritis. She was HLA-B27 positive, which made the diagnosis. Diagnosis was done by the rheumatologist. She had an incidental bacterial ulcer, which we scraped. It responded nicely, but it brought with it vascularization. You can see that in the second picture. The ulcer did not cause a melt, but the vascularization resulted in melting of the cornea. The infection did not cause a melt. This was because probably the immunity was high in her blood. We actually took her to the OT and researched the pannus, and then she started scarring down. And she was put on steroid sparing because she was young, but immune modifying agent in the form of mycophenolate mofetil. Last but not the least, factitious disorder or self-induced ocular surface disease is a diagnosis of exclusion in older children. This largely mimics immune because it can be bilateral. Only it is important to note that there is very little or no intraocular inflammation. And the children almost always have access to the inferior part of the eye, as you can see in these pictures. This boy was putting sanitizer gel in the lower fornix to escape his online classes. So denying them the access and by admitting them and observing helps. You can see that the lesions have become lesser in the second picture when he was in the ward. Because factitious disorder, if confirmed, can spare the child of the prolonged and deleterious effects of long-term immunosuppression. Thank you so much. Thanks once again for the opportunity to be in this wonderful meeting.